So welcome back to part 2 of our early ACS results show. We just heard from Kathy about 5 years of hard work from the sites and the teams at the coordinating centers. And what we want to do now is turn to Pierluigi Tricocci, who's going to tell us what we learned from all of that hard work that the sites put in. So Pierluigi, welcome.
Thank you, Kristen.
And tell us what we found.
So yeah, I will present the main feature of the trial design and the result of the trial, and just to remind you everyone how the trial was actually done and what the specific feature of this trial. Then we'll go to the results. So the first slide I'd like to present is this one. It is a very important slide. I think Kathy already in her presentation mentioned how this was truly a collaborative effort between several institutions, between two big academic institutions, the Duke University, the Duke Clinical Research Institute in particular, and the effort here was led by Dr. Newby. and then the TIMI study group in Boston, and the lead investigator of the TIMI group was Dr. Bob Giuliano, and also we had an executive committee chaired by Dr. Braunwald and co-chaired by Dr. Califf and Dr. van der Werf. And also the clinical operation of this trial were truly global. We had collaboration with the Vigor Center in Canada, with the sponsor who managed the sites in country outside North America. And also like to acknowledge our colleagues in Leuven that led by Dr. Sinaf that helped me in and helped us to do the clinical helpline job, and actually they avoided us to wake up in the middle of the night, and also they did a very good job making sure that the protocols follow the site and the helping sites with clinical questions. So why was the early ACS design? And there was a question that was an answer about the appropriate use of a glycoprotein 2B3A inhibitor, and the question was actually left open in the guidelines on whether routine early use, upstream use of the eptifibatide was better compared to a delayed provisional use where the decision whether to use a glycoprotein 2B3A inhibitor was left at the discretion of the treating physician at the time of the PCI. So the early ACS trial really compared a strategy of a routine early administration of eptifibatide to all patients shortly after the presentation for a non-ST elevation acute coronary syndromes, versus a strategy of a delayed provisional eptifibatide administration at the discretion of the physician following the coronary angiography and prior to the PCI. And this slide shows the study design and emphasizes the inclusion criteria. So the goal of early ACS was to include patient with non-ST segment elevation, acute coronary syndromes, and high-risk feature. And also, we wanted to enroll patients who were scheduled to undergo an early invasive strategy. So cardiac catheterization within the first 2 or 3 days after the hospital presentation. More into detail, patients were eligible for the early ACS trial if they have at least 2 of those 3 high-risk criteria, so an age equal or greater than 60 years, positive biomarkers, either CKMB or troponin, or ST segment depression or a transient ST segment elevation on the ECG. So a patient, in order to be eligible, should have had at least 2 of those 3 criteria. And then we tried also to enrich the population that was younger than 60-year-olds. So there was an inclusion criteria that was actually added during the course of the trial to allow the participation of patients within the age range of 50 to 59, documented history of cardiovascular disease, and a positive enzyme, so positive troponin or CKMB. So also, patients were required to be randomized within 12 hours of hospital presentation. I think this is one of the key features of the trial that probably make the trial a little bit harder to enroll, and was probably one of the explanations why it took so long to have the trial completed, but was actually a requirement that was needed in order to answer the question. So the question was what happened if we administer the eptifibatide early, immediately after the hospital presentation. So and also, I mentioned before the invasive strategy. So a requirement of the trial was the early invasive strategy, or the cath, was to be performed between 12 hours and 96 hours, particularly not sooner than 12 hours. That was another key feature of the trial. The trial wanted to show what happened if we give the drug for a significant amount of time, and we picked as 12 hours pretty much to be at least a minimum time to observe any difference between the 2 strategies. At the bottom of the slide, you can see also the primary endpoint of the trial was the composite 96 hours of death, myocardial infarction, recurrent ischemia requiring urgent revascularization, and thrombotic bailout, which basically is the use of a glycoprotein 2B3 inhibitor after a PCI was started to treat a complication. The key secondary endpoint was the composite 30-day of death or myocardial infarction. Try to advance to my next slide. Key exclusion criteria in this trial were a history of bleeding that indicated an increased risk of bleeding if the eptifibatide was to be administered. So either an active bleeding or a recent bleeding or a recent surgery or trauma. Also, patients with prior intracranial hemorrhage were excluded, or also patients with a recent ischemic stroke were excluded, and also serious concomitant illnesses or pregnancy, which would limit the prognosis, the life expectancy of the patient, or pose the patient increased risk if the study drug was used, and end-stage renal disease with dialysis within 30 days. So this is, I think, another important feature of the trial to highlight. Many trials with antithrombotic therapy, they excluded patients with renal insufficiency, particularly for those drugs which are renally cleared. Now, eptifibatide is renally cleared, but we still wanted to observe if the drug worked also in this type of population, so which is a very important population, and so those are patients we see every day. So the only limitation regarding renal disease was dialysis done in the last 30 days. Otherwise, there was no cutoff for creatinine or creatinine clearance. And then there were a last exclusion criteria that prevented patients for which the use of a direct thrombin inhibitor, factor Xa inhibitor was planned, or patient who received anyway some treatment with glycoprotein 2B3 inhibitor. Now, while the trial was on, there were new trials published and new guideline recommendation, and so in particular there were trials showing the bilirubin was good drug to be used at the time of PCI, and so the early ACS with amendment allowed the inclusion of patients with where the bilirubin was planned to be used at the time of PCI, and then an amendment to allowed also the use of bivalirudin as an upstream treatment, like in a QD trial setting, so like a background type of antithrombin therapy, and also allowed the use of fandaparinux after the results of the OSS5 were published. Now, this slide describes how the drug was used. And this, I think, is a very, very important slide to understand how the trial was done, how the trial was designed. So, after randomization, patients were randomized to receive either eptifibatide or placebo. So eptifibatide was administered with a kind of a novel regimen. So a double bolus. So patient received a bolus of 180 microgram per kilos, and then an infusion of eptifibatide followed by a second bolus after 10 minutes from the first of 180 milligram per kilo. That was this is a regimen that is actually approved for PCI patients, but was never actually tested in an upstream setting. So that was another novel feature of the early ACS trial. So, importantly, also patients with renal, with some type of renal disease, in particular those who had a creatinine clearance of less than 50 milliliter per minute, received an adjusted dose of eptifibatide, so an infusion which was cut by half, so 1 microgram per kilo per minute instead of 2. So this is as concerned the active group. The control group received placebo in a double-blind fashion, so they received some type of bolus infusion, but not actual drug. So patients, as I said before, were scheduled to undergo a coronary angiography. So they received a blinded infusion with eptifibatide or placebo for at least 12 hours and until the moment of the angiography. Then, for those who were treated with PCI, according to local practice, or the physician could decide whether to switch that patient to an active treatment with eptifibatide. So before the PCI started, the investigator could request the so-called active PCI kit. So at that point, the patient was switched to an active treatment, and then after that moment, the patient continued with open-label infusion of eptifibatide. So at that moment, the investigator was 100% sure that the patient was receiving the actual drug. We just didn't know when the treatment was started. And this because, again, the question of the early ACS was to understand the difference between an early upstream treatment versus a delayed provisional use. But we knew that eptifibatide is a drug that is effective at the time of PCI, so the trial could not prevent the use of an effective drug at the time of PCI. So the trial was initially designed to include a sample size of 10,500 patients, and the initial calculation was that the sample size would provide at 85% power on the primary quadruple endpoint, and an 85% power for the key secondary endpoint at 30 days. Along the way, there were some re-estimation of the sample size based on aggregate event review, and actually those review showed that the rate of the primary endpoint was actually higher than expected, and this allowed a mild reduction of the sample size. So the sample size was readjusted from 10,500 patients to 9,500 patients, and this still provided a 98% power on the primary endpoint, which was actually much higher than was originally projected, still maintain a good power, 81% for the secondary endpoint. And this slide shows how this was really a global trial. Patients were included in North America, in Europe, in Asia, in Australia, New Zealand, in South Africa, and approximately a third of patients was enrolled in North America, and 2/3 of patients was enrolled elsewhere, with, of course, Europe being the greatest contributor. And I think Katie already showed in the first part of this show the top enrolling sites, and this again shows the 20 top enrolling sites in the world. The one I just mentioned, the top enroller, Dr. Lisch from Austria, but of course our kudos goes to all those investigators in this list, and all those investigators who have contributed to the trial, you know, regardless of the number of patients. We can't say it
enough, can we?
Yeah. Even from 1 patient to 304 patients, we took everything, right?
Everyone.
So before I move to the results section, I want to stop here and see if Christian has any comment on the first part of the presentation.
I don't, because my question that I'm going to ask you about the first part really depends on you showing everybody the results.
Okay, okay. So that was
so if I can
that was
hold
an excuse for me to breathe, and but okay. So first slide of the result describes the baseline characteristics, and there are a couple of things that I'd like to highlight. First is overall, this slide shows that the intention of the trial to enroll high-risk patients was actually achieved. You see here, for instance, the age, 67, is much higher than what we would normally observe in clinical trial. A lot of patients, a third of patients had a history of diabetes or prior MI, and about 20% had moderate to severe renal disease. But probably the most critical feature in the slide is the troponin. You can see here that 84% of patients had positive troponin. That was, again, the intention of the trial, although we allowed to include also patients with negative troponin, but the intention and what we have emphasized with our investigator was that the patients that we were really looking at were those with positive troponin, because we know that the glycoprotein B3 inhibitor work particularly, or maybe only, in patients with positive troponin. So, and our investigator again did a great job here. 84% of patients had positive troponin, and also the majority of patients, 60% of patients, had some type of ST segment shift on the ECG. The bottom of the slide, there are other 2 important features. You can see that patients in early ACS presented pretty quickly to the hospital and were included very quickly. So the median time between presentation to the hospital and randomization was a little bit more than 5 hours. And again, so the investigators, they put a lot of effort in identifying this patient very, very early, in many cases in the emergency department. And despite during the course of the trial, the window for enrollment was expanded between 8 hours to 12 hours, we still have observed that the time from presentation to randomization really didn't change much. Those are the in-hospital management, and as you can see on the top, the intention was to include patients undergoing an early invasive strategy, and you can see that nearly all patients underwent early invasive strategy and received a cardiac catheterization, with a time from randomization to catheterization about 21 hours. And this is pretty much consistent with what registries have shown, like Crusade, for instance. So this is in line with what is the current practice in North America, in Europe, and in other countries. And also, as concerned the in hospital management, 60% of patients overall receive PCI, you can see also here that what I explained before, so the use of a provisional eptifibatide at the time of PCI, you can see here that about 25 to 27% of patients received the active drug at the time of PCI, regardless of what were randomized at the beginning. So that reflected the some practice pattern of care, and in fact we have seen the use of the provisional use at the time of PCI more frequent in the United States compared to Europe. And also you can see that patients, including early ACS, were treated with most modern therapy like beta blocker, statin, ACE inhibitor, and early clopidogrel. Again, one other feature of the trial was that stratification by the intention to use clopidogrel upfront, so outside of any revascularization procedure. You can see here that overall 75% of patients receive early clopidogrel. Again, there was some different pattern here as concerned the use of clopidogrel in North America versus Europe, where the use of the upstream clopidogrel was higher in Europe compared to what we observed in North America. Result slide. Of course, we probably would have liked something different, but that's why you do research. You don't know the answer. You try to provide an answer, and this is the answer of the early ACS trial. So the primary endpoint, remember, 96-hour composite of death, myocardial infarction, recurrent ischemia, and thrombotic bailout. And the rate of the composite endpoint was 9.3% in the routine early eptifibatide group versus 10% in the provisional eptifibatide group. So you can see that the p-value is not statistically significant in this case, p-value of 0.23. And the point of estimate of the effect is about around 8% reduction of this quadruple endpoint in the early eptifibatide group, but this did not reach the statistical significance. And also you can see here that none of the components of this composite endpoint taken separately reached the statistical significance. So death was very similar between the two groups. There was a little, probably numerical reduction in the number of deaths or MI, but again, not statistical significant. And again, also the composite of death, MI, recurrent ischemia was not significantly different between the two groups. And actually, the way the trial was designed was that if the primary endpoint was negative, none of the other secondary endpoint could have been declared as significant, even if we found some statistical difference here. And this is the Kaplan-Meier curve concerning the primary endpoint. You see here kind of an odd shape of this curve, but it's not like the smooth and round Kaplan-Meier curve that probably most of the audience is used to seeing. But there are two reasons for this. One is that, of course, this is magnified. So those are hours. You can see on the x-axis. Those are really what happened during the hour. And second, as you know, it's very difficult to diagnose recurrent MI in patients who present with positive enzymes in the first hours after presentation. So you cannot really see a new rise and fall pattern of the enzymes to be sure that the patient had a new MI. So first, and second, as I showed you, many procedures occurred during the around 22 hours. And of course, we have seen a lot of events. Usually in this modern ACS trial, most of the events are observed at the time of the PCI. So you can see here at the around between 16 to 24 hours where the event really start to accrue. And those are the 30-day results. And so the key secondary endpoint of the trial, again, was the composite of death or MI at 30 days. This was a very important point for us because those are two clinically relevant outcomes. And also, many of the past trials with glycoprotein 2B3 inhibitor have used this endpoint, so that also allowed us to compare the results of the early ACS with results of prior trial with glycoprotein 2B3 inhibitor. You can see here there was a numerical difference in the occurrence of death or MI between the early eptifibatide group and the delayed eptifibatide group. So 11.2% in the early eptifibatide group versus 12.3% in the delayed group. And here the p-value was 0.079. So we felt that we could call this like a trend toward a reduction of death or MI at 30 days, although the result is not statistically significant, and also there may be uncertainty on what can actually be defined as a trend. I don't think this is really clear cut, but certainly one can see here that there was something going on in the early eptifibatide group as concerned the 30-day outcome. And but there was no difference in the occurrence of death. The percent of patients who died at 30 days by 30 days was identical in the two groups. And again, there was a trend toward less ischemic event overall, like death and recurrent ischemia.
So Pierluigi, you're emphasizing this trend, and you know, it's always enticing when you see a 0 in front of the first number and the p-value. Unfortunately, it's not. But this is pretty consistent with other 2B3 inhibitor trials and the pooled looks at these, right? This is in the range of what we might have expected.
Yeah, I think yes. And actually, I have a slide with showing what happened in other trial compared to what happened in early ACS. But yes, to respond to your question, the size of effect that we observed in early ACS was actually absolutely consistent with what was observed in prior trial, which used the glycoprotein 2B3 inhibitor upstream.
So the sites might be wondering, after you presented your earlier slides that showed that we reduced the sample size from 10,500 to 9,500, did we make a mistake? If we'd have gone to 10,500, would that have been 0.05?
Sorry. Now, so definitely nothing would have changed on the primary endpoint. The second endpoint, as you can see, the power of the trial went from 85% to 81%. So we increased by 4% the chance to have negative finding by chance. But we also need to say that the way, as I said before, the way the trial was designed and the statistical method were written is that if the primary endpoint was negative, all other endpoints were considered to be negative. So probably even including 1,000 additional patients would have changed the interpretation of the results, I believe.
And did we do any post hoc power calculations to find out what it would have been at 10,500? Probably
you will know this better than me.
Of course we did. That was the first thing we looked at, and it wouldn't have made any difference.
Any difference?
Yeah.
Okay.
So we still would have been non-significant, but always interesting to think about.
Yeah, but I think and I will show the slides at the beginning, and I think the result of this trial needs to be put in perspective of everything else has been shown for early ACS. And I think overall, with the size of effect in this range, I don't think probably even having a p-value slightly positive would have completely changed the way a glycoprotein B3A inhibitor could be used. So this is the Kaplan-Meier curve at 30 days, and in this case, this is the shape of the curve. Yeah, still not positive. So every way you looked at this, the p-value is not positive. But as I said, the results at the end of the day are not inconsistent with prior trial. Those are the pre-specified subgroups to see if there was anything with any particular baseline characteristic which makes the effect of the eptifibatide different. And you can see here that there is nothing, no at least statistically significant differences according to the subgroups as concerned the 96-hour endpoint. Although you can see, for instance, in troponin positive patients, the bar tends to go more on the side of the early eptifibatide better than on the other side, while the negative troponin tends to go on the other side, although which again is consistent with the other trial, but again, no conclusion can really be drawn from this. And the same pattern, which was already shown in some analysis in the past, is true for diabetes, where patients with diabetes tend to do a little bit better if they are treated with more aggressively with a glycoprotein B3 inhibitor. As concerned the 30 days, again, none of those subgroup interaction were statistically significant, but again, consistent with other with the results of other trials with glycoprotein B3 inhibitor in the past, you can see that there was a trend in patients with positive troponin. They tended to do better if they were treated with early eptifibatide, while the effect of troponin negative, according to the subgroup analysis, tends to be a little bit more neutral. And also, interestingly, one of the embedded questions of the trial was what happened if you use clopidogrel and upstream eptifibatide at the same time, because this is another unanswered question, and we try to address this in an indirect way by stratifying patients by the intent to use of early clopidogrel. And you can see here that patients who actually received early clopidogrel tended to do better if they were treated also with eptifibatide. Now, why? So there seems to be some additional effect of a therapy with clopidogrel and eptifibatide, but this again is not clear. Why is that? If this may just reflect that patients who were treated with clopidogrel were in different part of the world, there were different patients. So, and I think from the early ACS database, an analysis that will try to explore the interaction between clopidogrel and eptifibatide will be done, and that will be very interesting to see. But I wanted just to emphasize this data. But again, those are subgroup, although I made some comments, those are subgroup analysis, and none of those interaction were statistically significant, so we really cannot conclude anything based on those subgroup analysis. So
I'm curious, the one subgroup that you didn't talk about that you know, has been a particular point of controversy with the glycoprotein B3 inhibitors is the interaction with sex, with male or female sex. And What did we learn, if anything,
Yeah.
from this trial about whether we should or shouldn't use these drugs in women?
Yeah. Yeah, as you know, there was a controversy in the past. There was some analysis showing that women treated with glycoprotein B3 inhibitor, they may have a worse outcome. But also those analyses have also shown in the past that if you pick the right women who have the disease of interest, there was not really any difference between women and men in the way glycoprotein B3 worked. But still, there was this controversy about potentially harmful effect of glycoprotein B3 inhibitor in women. What have we learned in early ACS is that the effect of eptifibatide between women and men is absolutely identical. I could say at least that.
Certainly if we pick the high-risk population and
Exactly.
use it in the context of an aggressive modern intervention strategy.
Exactly. I mean, if you pick the right patient with positive troponin, so have the disease of interest and have the high-risk feature, you see that the drug works the same in women or men. So I think those results are reassuring for those clinicians who may still like to use the drug in clinical practice and may have had some concern about women. I think that what the early ACS really, I think, clears this controversy. Bleeding, of course, the efficacy needs to be weighted and balanced against the risk of the drug, and you can see here that actually there is a price to pay if you treat those patients more aggressively with early eptifibatide. As you can see, there was an increase in the risk of bleeding. You can see an increase in the risk of TIMI major bleeding and TIMI major or minor bleeding, so any TIMI bleeding, and also increase in the risk of moderate or severe gasto bleeding. And also there was an increase in the use of blood transfusion, red blood cell transfusion in particular. So again, any potential efficacy of early eptifibatide needs to be balanced against this risk, and we see here there is probably 1.5 to 2 times increase in the risk of clinically significant bleeding when early eptifibatide is used compared to a more conservative strategy. And also, the slide shows also that the bleeding at the time of CABG were not really different. Although when we do trial and we have to do with surgeons, this always, particularly when we do trial with antithrombotic medication, there is also always concern from the surgeon point of view whether the drug is safe at the time of surgery, and also you can see here that actually there was not increase in the risk of bleeding in time of CABG, which is consistent with the pharmacology of the drug. I mean, this drug has a short half-life, 2 hours, so basically most of the patients in CABG were almost or completely clear from the drug when they received the intervention. So really, we did not expect to see anything in the CABG population, given the short half-life of the drug. Also, other safety endpoints that were looked at in the early ACS were thrombocytopenia, and also there were no differences in the occurrence of thrombocytopenia, and there were no differences in the occurrence of stroke. And then overall, the rate of stroke in the early ACS trial was low, below 1%. So this is what we were talking about before. So those are the trials past trials with small molecule glycoprotein B3A inhibitor. I'm sure everyone is familiar with this trial at Pursuit, the Prism Plus, and also the Paragon B and A that were done with lamivudine, where the Prism Plus were done with tirofiban, and Pursuit with eptifibatide. And you see, overall, the size of effect is around, this is the 30-day death or MI rate. The size of effect is 80, it's a reduction of event in the order of 12% magnitude. And this is pretty much what we have shown in the early ACS trial. And also, the early ACS was different from those other trials, because the other trials were trials that were done against placebo, while the early ACS gave the possibility to use the drug at the time of PCI, so it was more like a strategy trial. And there was another strategy trial that was published 1.5 years before the early ACS, so the acuity trial, and also the acuity trial did not show a benefit of an early administration of glycoprotein IIb3 inhibitor compared to a delayed use. And you can see here the pooled odds ratio of early ACS in acuity, so around 0.92 odds ratio, so 8% reduction in the occurrence of death or myocardial infarction at 30 days. So if we consider all those trials which tested upstream glycoprotein IIb3 inhibitor versus placebo or versus delayed use of glycoprotein IIb3 inhibitors, we observe an estimate of 11% reduction in the occurrence of death or MI 30 days. So overall, an effect, probably a modest effect of the drug when used on a routine basis in all comers patients with non-ST segment elevation, acute coronary syndromes. So what have we learned from the early ACS? So what we have learned that in patients with high-risk non-ST segment elevation acute coronary syndromes treated with an early invasive strategy, the use of a routine early eptifibatide compared with a delayed provisional eptifibatide used at the time of PCI did not significantly reduce the primary composite of death, myocardial infarction, recurrent ischemia with revascularization, or thrombotic bailout at 96 hours, resulted in a trend toward a reduction of death or MI at 30 days, but there was also a significant increase in the risk of clinically relevant bleeding. And also, in conclusion, the results of the early ACS trial clearly don't support the routine use of early eptifibatide in patients with non-ST segment elevation acute coronary syndromes treated with an early invasive strategy. Although, if we were able, or if we will be able to identify some certain category of patients at high risk, but with a low bleeding risk, the therapy with early eptifibatide could still be considered. And certainly, our results, they don't impact the use of the eptifibatide at the time of PCI. So our results have nothing to do with the decision of using the drug during a PCI, and which has been shown in prior trials that is a viable strategy.
All right, thank you, Pierluigi.
You're
that
welcome.
was a great run through of the results and you know what we ended up with at the end of 5 years. And I mean, I think you should be congratulated. Certainly, the site should be congratulated, and the teams at the coordinating centers at Canada, Leuven, and here for really putting together a terrific trial. Everybody should be proud of this result. It's, you know, whether the p-value falls one way or another is really not the most important thing. It's that we answer important questions, and I certainly think we've done that. Why don't we take 1 or 2 questions? No? Okay. Okay. All right. So thank you, everybody. We look forward to working with you on the next trial. We hope to have you as collaborators and partners again, and thanks for joining us today for the early ACS results show.